Hello, my name is Brianna Aycock, and this is my partner, Cheyenne Hatch. And today we're going to speak to you about our journal article, Monocycline versus Placebo for Patients with Alzheimer's Disease. Some of the background on our article is the Alzheimer's disease affects 50 million people worldwide. It is the most common cause of dementia, which is a continuous decline in thinking, behavioral, and social skills that disrupts a person's ability to function independently. Alzheimer's disease is associated with immune-related and inflammatory genes. In Alzheimer's disease patients, beta amyloid is a pro-inflammatory agent that accumulates as Alzheimer's disease progresses and is associated with neurodegeneration. There is no therapy that has been proven to treat or delay the progression of cognitive and functional disability caused by Alzheimer's disease. Monocycline is an anti-inflammatory tetracycline that can cross the blood-brain barrier and inhibit pro-inflammatory microglia. In vitro and in mice, it was shown that monocycline protected against alpha beta-induced cell death, neuronal death, and leaning deficits. These concepts set the basis for this trial, which was to investigate whether 2 years of treatment with monocycline slowed the decline in cognitive and functional abilities in people with mild Alzheimer's disease, and whether giving monocycline at higher doses enhances efficacy. This article doesn't reference any significant findings from previous trials. This study was conducted to determine if 24 months of monocycline treatment can lower cognitive and functional decline in patients with mild Alzheimer's disease. Before this trial, there were no disease-modifying treatments for Alzheimer's disease. They decided to study monocycline because it is an anti-inflammatory that protects against the toxic effects of beta amyloid in vitro and in animals models of Alzheimer's disease. The trial was funded by a grant from the Efficacy Mechanisms and Evaluations Board, funded by the National Institute of Health Research and the UK Medical Research Council. The monocycline and placebo were manufactured by Mode Pharma Limited and distributed to participating cities by Polar Speed. This trial was conducted at 32 National Health Service memory clinics in England and Scotland. The primary author, Robert Howard, MD, member of the Royal College of Psychiatrists, is employed at the University College London Division of Psychiatry. And there were numerous other authors that are listed with their degrees on the handout. The trial design was a prospective, experimental, double-blind, randomized placebo trial with 3 arms. The primary outcomes was a decrease in standardized mini-memory mental state examination with a score from baseline to 24 months, an increase in Bristol Activities of Daily Living scale from baseline to 24 months. Secondary outcomes is safety and concurrent infections. For methods, the inclusion criteria was diagnosis of possible or probable Alzheimer's disease, older than 50 years of age, could give informed consent for involvement, had an standardized mini mental state examination score of 24 to 30, had a caregiver to supervise medication and complete the BADLS assessments. The exclusion criteria was the tetracycline allergy, women of childbearing age, uncontrolled serious concomitant illness, stage 3B to 5 chronic kidney disease, moderate liver disease, systemic lupus erythematosus, and participation in another clinical trial in the previous 28 days. The participants were randomized to receive 400 milligrams monocycline hydrochloride, 200 milligrams monocycline hydrochloride, or placebo. Modified release capsules contain 100 milligrams of monocycline hydrochloride, and placebo capsules resembling the monocycline hydrochloride were dispensed in foil blister packets every 13 weeks. The trial group dosing was 400 milligrams monocycline hydrochloride, 2 100 milligram capsules in the morning and 2 in the evening, 200 milligram monocycline hydrochloride, 1 100 milligram capsule plus 1 placebo in the morning and in the evening, placebo, 2 placebo capsules in the morning and evening. Patients visited the clinic at baseline week 2 and months 3, 6, 9, 12, 15, 18, 21, and 24. Information on adherence and adverse events were recorded at each visit, and outcomes assessments were conducted at baseline in months 6, 12, 18, and 24. The duration of treatment was 2 years. The primary outcomes were measured by completing a standardized mini memorization, SMMSE, standardized mini mental state examination, and the BADLS. The SMMSE measures cognition and the BADLS measures functional ability. Based on previous studies, it was estimated that 24 months assessments would be available for at least 80% of surviving patients, which would provide a 90% power. This trial set their power at 80%, but did not state whether it was met or not. We assumed that our alpha is set at 0.05 by looking at the p-values in our study findings. The statistical tests used in this trials were Kaplan-Meier curves, log rank tests done by SAS software, two-sided test, and Poisson regression models were used in this trial.
So for our results, the enrollment, 886 patients were screened for eligibility, but only 544 were actually randomized. The trial was multi-centered, and it included 32 National Health Service memory clinics with secondary specialist services for people with dementia in England and in Scotland. It doesn't state how they were distributed across these centers. For baseline characteristics, of the 544 patients that were randomized in this trial, they were similar between groups at the beginning of the study. Those baseline characteristics are age, sex, race, home circumstance, duration of symptoms, the SMMSE score, and the BADLS score. So our study findings or efficacy outcomes, this trial found that minocycline hydrochloride 400 milligrams was poorly tolerated, and only 53 out of the 184 patients completed the full duration of the treatment, which was significantly lower than the 200 milligram or the placebo groups, with a p-value of less than 0.001. Significant reasons for stopping this treatment were GI symptoms that was greatest in the 400 milligram group with a p-value of 0.001, dermatologic adverse effects greatest in the 400 milligram group with a p-value of 0.02, and dizziness greatest in the 400 milligram group with a p-value of 0.01. The combined minocycline groups had a mean 4.1 point reduction in the SMMSE scores compared to the placebo group with a 4.3 reduction. The minocycline groups combined had a mean score 0.1 higher than the placebo with a p-value of 0.90, which was insignificant. The decrease in the mean SMMSE scores was more in the 200 milligram group than in the 400 milligram group, but it was not significant with a p-value of 0.08. The worsening BADLS was similar between these, but not significant with a p-value of 0.77. There were two assumptions made in this trial to estimate what effect the missing outcome data of the 41 patients that had baseline assessment but no other assessments might have had on the results. Method 1 was assumed that for the first 6 months, patients declined 3.9 points and then declined 1.1 points every 6 months for the rest of the trial. Method 2 stated that the patients with no assessments after baseline declined at an average rate of those with the assessments after baseline. The results were shown to be relatively similar between those with the primary analysis. The only significant differences that were seen between the 400 and 200 milligram groups, and it had a p-value of 0.05. Similar analyses were performed for the BADLS, and For method 1, it was assumed that the scores worsened by 3.7 points during the first 6 months and then by 1.9 points every 6 months for the remainder of the trial. And method 2 assumed that it worsened by 1.5 points during the first 6 months and then 1.9 every 6 months after for the remainder of the trial. The results were shown to be relatively similar to the primary results, and there was no indication of benefit for minocycline for patients with shorter or longer duration of symptoms, lower or higher baseline SMMSC scores, or for men versus women. And they stated a borderline significant trend for greater efficacy in younger patients. For the adverse events, there were 252 reported serious adverse events, and the most common were neuropsychiatric and cardiocirculatory. The number of serious adverse events was higher in the placebo group than in the 400 milligram group or 200 milligram group. Patients experienced gastrointestinal symptoms, which was the main reason for stopping the trial. The numbers of gastrointestinal serious adverse events in the minocycline groups were low and no higher than in the placebo group. Skin-related toxic effects, such as pigmentation, were more frequently reported with minocycline than the placebo, with a p-value of less than 0.001, while only 6 were considered severe. Impaired renal function was another adverse event stated in this trial. A total of 28 patients died during the study, 10 who received 400 milligrams of minocycline hydrochloride, 6 who received 200 milligrams of minocycline hydrochloride, and 12 who received the placebo. And 15 of 28 patients stopped the treatment before dying, and 1 patient died without starting the treatment. So for our author's conclusion, the authors concluded that the 2-year minocycline treatment for patients with mild Alzheimer's disease does not result in any clinically significant difference in the rate of decline of cognitive or functional ability. Their conclusion accurately portrays the study results found because there was no statistically significant data to support the minocycline hydrochloride had a positive impact on the rate of these 2 scores. The authors of this trial avoid bias by being blinded along with the participants of the study. They explain their results with facts rather than opinions, which also avoided any type of bias. There are many strengths that were listed in this trial, some of them being that it was based on a broad network of academic and National Health Service memory services, and the wide eligibility criteria facilitated the recruitment of participants, many of whom had physical comorbidities and were representative of patients with mild Alzheimer's disease. Outcome measures were limited in number, easy to administer reliably by trial staff, and chosen because any differences between minocycline and placebo would have clear clinical relevance. Some of the limitations that the authors listed are that biomarkers were not used to confirm Alzheimer's disease diagnosis because these and apolipoprotein E genotyping are not routinely available within the National Health Service. It was stated that non-adherence was problematic because few patients in the 400 milligram group completed the full 2 years of treatment, and there was only moderate adherence in the 200 milligram and placebo groups. Differential follow-up could have been a potential bias of the trials in this result. And after completion of this trial, we're still unsure of a medication that could aid in the treatment of Alzheimer's disease. So our professional opinion and reflection, we noticed a few other weaknesses that weren't stated in this trial, and these were that comorbidities and other medications were not listed. Both comorbidities and medications could either increase or decrease the effect of minocycline when taken together, which could have impacted the results of the trial, either positively or negatively. We agree with the author's conclusion of the trial because there was no statistically significant data to disprove their conclusion. Our opinion was that there's not enough evidence to decide if the benefits of the treatment outweigh the cost or risk because the results showed that the treatment did not work. The patients in this trial are similar to the patients in our community because Alzheimer's disease patients in our community decline pretty quickly. And the study investigates outcomes that our patients would care about because they would do anything to get their lives back to normal. They would like to build their cognitive and functional abilities up so that they could prolong their lives and live a somewhat normal life. From the results that were given in this trial, we believe that we should continue trying to find a way to treat Alzheimer's disease by either medication, working with them on their cognition and functional skills, or both. Thank you.